This is Dr. Weich Coleman. We're going to be doing a very dense cataract today. As you can see, just on the first look with the microscope, it's what I would call a black rock. We don't see many of these in the United States. And the consideration could be to do SICS here and not even attempt to phaco, but the cornea looked good. It's a relatively young person. I'm not sure how they got a cataract this dense at that young of age. But in any case, I decided I think it will be amenable to a phaco. So obviously we need to stay in the capsule. We have no significant red reflex. One point is when you inject sugarcane, you can just pull it out of the eye, pull some air back into the cannula, into the syringe, and then inject the air, and you don't have to use a separate syringe and cannula for the air injection, and it's one less pass back and forth with your scrubs. We use some bubbles to protect the endothelium, but in general, the cornea doesn't stain very fast with trypan blue, so if you don't leave it in long and get the viscoelastic in pretty quickly, that's not too much of an issue. Recently, I've started stabilizing the eye 180 degrees from where I'm making my incisions with the Connor wand. I used to use 0.12s, and if somebody is really having trouble fixating straight ahead, I'll go to the 0.12s and grasp the conj, but it tends to lead to subconj hemorrhage, so I've gone back to the Connor, and I think that's a better plan. You can see here, the Rexus is coming around fairly easily. You got to balance here because you need the Rexus to be big enough that you can take this very dense nucleus through it, but not so big that it has a tendency to tear out. And these all have some tendency to tear out because you really can't compress them with viscoelastic. So we're being careful. We're trying to ride a fine line, but it can really make the rest of the case a lot more difficult if you do not have an adequately sized Rexus. So just try not to go too small because you're scared of it tearing out. As far as hydrodissection goes, there's people who recommend no hydrodissection in dense cataracts like this, and I can see that argument. But many times the cortex is basically liquefied, or there is very little cortex remaining, so I think it's okay to do some general hydrodissection. And it's very low risk of a capsule rupture. You just don't want to create a fluid wave that can blow out the posterior capsule. It helps free it up, especially since we're going to use a MyLoop in this, which is totally necessary, and will probably cut our phaco energy in half. So we've done a very gentle hydrodissection. We're careful. We're unzipping it all the way around without blowing out the bag. So now I'm going to reinflate with some Viscoat so that I have an adequate anterior chamber and have plenty of room for the MyLoop to be used. Now, with the MyLoop, it comes with what I call the training sleeve. That's a little accordion type piece of rubber at the end of it. I remove that so I have more freedom to move it where I need to in the eye. I think the MyLoop is better utilized with that little guard removed. You can just pull it straight off with the MyLoop retracted. So we're going to fully extend the MyLoop, and you have to make sure you're under the Rexus in all locations. And if you have trouble visualizing that, retract it some, and then make double sure that it's under the Rexus before you fully extend it. And that's what I'm doing here. I'm just making sure I can see the Rexus edge sitting on top of the wire of the MyLoop. And in this case, it is under the Rexus. And then I'm going to rotate it a little bit further than I want it to go. I ideally want it to be 180 degrees vertically aligned so that I'm going to get a clean 1/2 crack. So I over-rotate and then rotate back slightly to make sure it's in the position I want it. The whole lens complex will come up in the anterior chamber if you don't use your second instrument to hold the distal portion down as you finish the MyLoop. But here we got a clean crack. It's still in the bag, which is ideal. That's what we want. With our fellows, I always emphasize that the easy cases with softer nucleus are training for very dense cases. So we want to really get good at taking clean quarters out of the eye so that we have that methodology down. When we get to a dense lens, we stick to that, and we're not lost in our methods. You always want to have a plan that even if you deviate from it, that you're trying to get back to it. And my plan is always to take the lens in quarters. And we've got to be very meticulous about cracking these nuclei. When they're hard as a rock, even if you have one residual fiber holding the 2/4 or the 2/2 together, it will make it very difficult for the nucleus to tumble into the phaco tip. And we're obviously in procedure 2 here on the Centurion, which is absolutely necessary for a lens this dense. And even if it looks like you get an adequate crack and you still have one fiber remaining, I would always go back, and even if a tiny piece is holding the 2 fragments together, I would get the Connor behind it and then use the sharp end of the phaco to make sure that it's completely cracked before you start your nuclear removal, and it will be much easier, and then it will tumble into the tip. And here we've got a slightly larger remaining fragment than a quarter. It's probably 2/3 that's left. So I'm going to go ahead and crack that one more time so that I can have a smaller fragment rotating towards the tip. And again here, just like in every case, I'm going to be very meticulous about using force between the conner and the phaco to make sure that I've got a clean crack and that nucleus is going to tumble into my tip without much problem. And you can see this is a very, very hard lens. It's got a black appearance to it. When they look like that at the slit lamp, you can prepare for a very high phaco time. And these sometimes are very difficult to groove, so the MyLoop has been a great tool to have that not only lowers the phaco energy, but it gets you a clean crack of the hemisections at the beginning of the case and makes the rest of it go much more smoothly. So now we have like maybe a 1/6 remaining, a small fragment. It's completely free from the other fragment. It's going to tumble into the phaco tip with no problem. And here I'm phacoing posterior, so iris plane or just below to protect the corneal endothelium. Now, as I remove more fragments, I'm going to have to be more careful of the posterior capsule, but when there's a bulk of nucleus protecting the posterior capsule, the risk of it coming forward and causing a posterior capsule rupture and the need to do a vitrectomy is very low. As we progressively remove more fragments and there's less remaining to protect us, we got to be more meticulous about protecting deep with the conner to reduce the risk of a PC rupture. Now, my rule is always I'll try 3 times to engage the nucleus with the phaco tip and bring it up into the anterior chamber and crack it. If that doesn't work, I always rotate 180 and just take it look like I took the first hemi, and that's what happened here. It was difficult to engage. I rotated 180, and I'm just going to repeat the process that I used for the first hemi. I don't do that in every case, but if we try to engage it and bring it in the anterior chamber 3 times, it's very unlikely to come, and then the plan would be just go ahead and reach out pretty far peripherally so that you have some mechanical advantage to be able to rotate the nucleus, and that's where it becomes an advantage to have done a little bit of hydrodissection so that the nucleus is able to spin 180 if you need to do it to get it in the anterior chamber and crack it into quarters. So here we've cracked it into pretty clean quarters, and the nucleus, even though it's extremely dense, is tumbling into the phaco tip with a fair amount of ease. And you can see the phaco energy is getting fairly high here. I think we'll end around 32 or something like that. But in any case, without the MyLoop, this would have probably been a CDE of 50. And it's important to remember here that you'll have a few small fragments in most cases floating around in the anterior chamber. You're not going to be able to remove any of those without great difficulty using the IA. Usually we can leave a couple of fragments, we can come back and get it with the IA, but nothing is coming out with the IA in the case of a nucleus this dense, so it all needs to be removed with the phaco so that you don't have to come back in mid-IA and use the phaco to remove a stubborn piece of nucleus that you can't get to go in the IA, even trying to force it in with the conner wand. Now, not much cortex remaining, more than I would expect in this case. Actually, it wasn't totally liquefied. So we're just carefully removing it. In the cases of nuclei that are this dense, we typically have some zonular weakness, so I would be careful. I would be gentle with the polishing, so we're all going to do a little gentle polish and clean it up as good as we can. But just be aware that these are cases that typically have some significant zonular weakness, and you should be aware of that going into them, that this is not a normal eye with a cataract that looks like that. So you can see the case has gone well. Lens is inserted without problem. We didn't have any nuclear fragments remaining during IA, and that didn't slow us down. There's a few portions edited out of this case, but this was just over 10 minutes with one of the most dense nuclei that you'll probably ever see, and a CDE in the 30s. But because we phacoed while pointing posterior and staying away from the endothelium, this patient had a good result in a clear cornea in a couple of weeks with 20/20 visual acuity, and it was a great success. At this point, we'll do a little hydration. We were careful not to get wound burn and keep plenty of fluid flowing through the eye when we were doing phaco. Wound burn is rare in modern times, but you do see it every now and then, so be aware to always keep fluid flowing through the eye on a dense cataract especially. Thanks for watching.